Welcome back. Let's just dive right into this highly requested explainer. This is part 2 of our masterclass, where we are going to completely transform complex surgical modifiers into an intuitive, rule-based logic tree. Now, if you're a medical coder, a clinical documentation specialist, or maybe you're gearing up for your CPC or CIRCC exams, you already know that modifiers can absolutely make or break a claim. So today, we're going to clear up all that confusion and build a bulletproof mental model for coding breast procedures.
Here is a quick look at our roadmap for today's explainer. We'll start with an anatomy recap, move into laterality modifiers, break down the add-on golden rule, tackle unbundling distinct procedures, run through some practical coding scenarios, and then wrap it all up.
All right, starting off with Section 1, our intro and anatomical recap. Okay, so biologically speaking, breasts are paired structures located right there on the anterior thoracic wall. Because of this, anatomical laterality is the primary engine that drives both your reimbursement and your clinical accuracy. Just think about it for a second. A pair literally cannot process a surgical claim on a paired organ without knowing exactly which side the surgeon operated on, right? This basic biological fact is the entire reason specific modifiers exist in the first place, and why they are absolutely mandatory in your daily coding workflow.
Moving right along to Section 2, anatomical laterality modifiers.
These 3 modifiers are essentially your foundational tools. They alert the payer exactly where the scalpel went. You've got LT for the left side, RT for the right side, and modifier 50, which is used when the exact same procedure is performed bilaterally, meaning on both the left and right breasts during the very same operative session. Honestly, whenever you are reading through a breast surgery operative report, your brain should immediately start scanning for laterality to figure out which of these 3 tools you need to pull out of your coding toolbox.
Now, you've really got to pay attention to the billing rules here because they can be wildly different. The Medicare 150% reimbursement rule dictates a single-line entry with modifier 50 for identical bilateral procedures. When you use that 50 modifier, Medicare typically pays 100% for the first side and 50% for the second side, and it's all billed on just a single line with 1 unit. But, and this is a big but, you must watch your payer contracts. Many commercial payers will actually demand that you list the procedure on 2 entirely distinct lines, appending RT on line 1 and LT on line 2.
Let's jump into Section 3, the add-on golden rule.
If you have your CPT book handy, you might want to circle this. Bilateral add-on codes for localization. We're talking codes like 19282 or 19284, and biopsy add-ons like 19082. Never take the 50 modifier. When a surgeon is in there placing clips or wires or doing biopsies, the coding is driven by the actual number of lesions and the imaging guidance they used, not just the side of the body.
So here is what that golden rule looks like in practice. Let's say a device is placed into 2 distinct lesions, one on the right breast and one on the left, using the exact same imaging guidance. You report a primary CPT for that first lesion, and then you use an add-on code for the second. You completely bypass modifier 50. You do not report the primary code with a 50, and you definitely do not report it with RT and LT separately. The base code covers your first lesion, the add-on covers the second. Simple as that.
Next up, Section 4, unbundling distinct procedures.
Okay, this maps out exactly when you need to unbundle. Modifier 59 is kind of your standard go-to tool for a distinct procedural service. But then we have the X modifiers, which offer much more granularity. XE is for a completely separate encounter or suite, while XS is used for procedures on separate organ structures. And finally, you have modifier 51, which is strictly reserved for multiple, concurrent major procedures happening in the exact same session. Like if a surgeon is performing a radical mastectomy and an autologous flap reconstruction on the same side at the exact same time.
Let's ground this in a real-world clinical timeline to show exactly why you have to append a 59 or XE modifier to a localization device when it happens before a mastectomy. Imagine a patient rolls into the preoperative holding area, right? A radiologist or surgeon places a localization wire or a clip. Afterward, that patient is physically transported down the hall to a completely different room, the operating room, where an open mastectomy is performed. Because that clip placement happened in a different suite prior to the main surgery, it is a distinctly separate encounter. Therefore, you report the localization device placement with the 59 or XE modifier. This guarantees it isn't inappropriately bundled into that major mastectomy procedure.
All right, Section 5, practical coding scenarios. Time to put you in the hot seat. Here's your first scenario. A surgeon performs an excision of breast lesions, which were identified by preoperative markers on both the left and the right breast. How exactly are we coding laterality here? Think back to our foundation. Is this a base code, and does it represent a paired organ procedure?
Well, the base code here is 1912-5 for the excision of a breast lesion identified by a preoperative marker. Because this is an excision base code, our rules tell us to definitively append the 50 modifier for a bilateral procedure. Our guidelines are super clear on this. For excision codes like 19125, if the procedure happens bilaterally, you append modifier 50. Easy enough, right?
Okay, let's try scenario 2. The surgeon performs a bilateral breast reconstruction with flat placement, CPT 15777. Do we use modifier 50 here? Now watch out, because this exact scenario is where so many coders get tripped up during their certification exams. It sounds like a standard bilateral paired organ procedure, doesn't it?
Actually, the rule completely shifts here. For this highly specific reconstruction code, you report it twice, and you entirely avoid modifier 50. The surgical coding guidelines say that for a bilateral breast procedure using a biologic implant for soft tissue reinforcement, code 15777, you have to report the code twice on the claim. You literally do not use modifier 50 in conjunction with 15777. This is the perfect example of why you can't just blindly apply modifier 50 to everything across the board. You always have to verify those code-specific exceptions.
And that brings us to section 6, our wrap-up and teaser. If you internalize this algorithmic mental model, I promise you your claim accuracy for breast surgery modifiers is going to be bulletproof. Just remember your steps. Start with the paired structure logic of LT, RT, and 50. Next, ask yourself if you're dealing with a localization or add-on code. If you are, drop that 50 modifier and use your add-on codes for multiple lesions. Apply 59, XE, or XS whenever your clinical timelines and structures represent a truly distinct or separate encounter. And lastly, always verify your specific codes for those weird exceptions, like the flap reconstructions that demand 2 line items instead of a bilateral modifier.
Before we close out, I want you to ask yourself a serious question. How much revenue is your facility losing every single day just because a coder blindly appended a 50 modifier instead of using an add-on code? Mastering these rules isn't just about passing a certification exam, it is literally about protecting the financial integrity of your practice. Thank you for watching, keep coding with confidence, and make sure to subscribe to Decode Healthcare with Harshal. See you in part 3.